this lecture. Please guys, make sure you are here. Otherwise you will have premature. If you want to avoid premature, then you must be here.
Right.
Because he is going to tell some secrets.
Yeah. Okay, so we have now until now the fertility sessions, then we have now here a lot of erectile dysfunctions. And basically erectile dysfunction is a condition which is increasing with the age of the man. We can do something, we can do nothing. There are a lot of factors which are determining, and we heard now how we deal that. But basically, when you're looking, what's the probability of a young man to have an erectile dysfunction? Then we would know. 30 years old? No, we will know. But he will have a lot of problems with the sex life, and this is why we complain that. And that's a key point where the organization team, the scientific committee, here decided to introduce a concept from premature ejaculation. Premature ejaculation not only an issue which is addressing the old man with a lot of comorbidities, a lot of pharmacology, which is diabetes, not balanced diabetes, but it's addressing other persons too. So we have to see how we can manage premature ejaculation, what we can do that in this issue, and we have to understand the mechanism behind that. I have no conflict of that. So basically, you see Joe. Joe's happy. Okay, why is Jane Doe happy? Because he had a good night last night. So he was happy. So you see, he's lucky man, and that's what we're addressing. The young man lucky. But it can be differently in other cases. So only the short, I know you're an expert, but only to remember what is the real phase. In the normal sexual arousal, if you have an excitement phase, well, the excitement can be because we have a good perfume, or a beautiful tube, the female, or beautiful shoes. I say, wow, that attracted me, and I get my excitement in the brain. It's a question of the brain. So we have the excitement here. Then one times we have an excitement in the brain. We have, fortunately, if the nerves are intact and they're not paraplegic patients, and have the spinal cord going down, we have an erection which is lasting a certain time. Okay, that's a plateau phase. It's highly important around the look at this plateau phase. And then, of course, the man is the problem that one time he gets too much excited. Well, it's going up, he got his climax, he got an orgasm, and has a resolution phase. That's a fact. So simply see, men are really monolinear. It's completely different from the circular model in the females. It's completely different. For females, it's around 25% of work on that, even as the younger females have a lower percentage. And now what happens, if that's a normal way, what happens in the case of a premature ejaculation? You see, the curve is pretty much the same, but the time until you get the climax is shortened completely. And where is shortened? Not for the time needed to get an excitement, neither for the time to get this resolution, but short is only this time of the plateau phase. So you see, this is remaining pretty much the same. Here's our problem. And we have to understand why we have a problem that we cannot maintain sufficiently our erections. So we have different disorders. So before we had already this discussion about the ED, the erectile dysfunction, but if you look in detail, we have retrograde ejaculation, we have delayed ejaculation, we have someone who has no ejaculation, someone has no feeling, anorgasmia. But you see the percentage, PE, is pretty high. So we have to deal with a condition which is higher than diabetes mellitus. It's around 10, the dependency of the age with 10, 40%. So you have a higher percentage. So more patients in your office will have a premature ejaculation than you have diabetes, or more have an infertility. More frequent is premature ejaculation. So what's the prevalence in the globe? Nobody knows. Between different data, 3%, 30%. Wow. Why we don't know that? What's our problem? So if you look at the data, it depends because of different definitions and different assessments. How we check that, it's geographical difference. It's not always the same. So you have to think about it. The agriculture is differently. If you look to the bonobos or the gorillas, okay, the animals die. In the animals, it's important that they get immediately sex, immediately ejaculation, because then maybe maybe the tiger is coming, so the gorilla is happy to have his baby born or have his sex, and then it's finished. He's happy. In some cultures in Africa, it's used to have a fast erection, fast ejaculation, because then it's a strong man. So that's a believing in some cultures. We have to be careful what means it. So the definition is just a problem what we have it. So if you look overall in Europe, we have not clear data. We have around 20% in US, similar in Europe. In China, recently was published 26%. So you see, that's not always the same. And then now I'm asking me why we have so different data. And I make here, I made right now a table for us to understand what's the problem here. And if you look at the problem, one of the most important is that with 12,000 persons in Europe, the people started from Horst published, while he got around 27%. The famous studies, the Lumen studies in the US had around 20 to 30%. So you see, there's a high prevalence. But we have always the problem, it's not everything equally. What's the assessment, how they assess it, what's the criteria definition. And now we have to understand what to do is which criteria we are going to use it, and that's a little bit changed in the last couple of years, and a lot of statistical problems have been there. Facts, yeah, we know something from premature ejaculation facts. So the premature prevalence is frequently underreported and underrecognized, because doctors are not going to ask the patient, how is your sex life? How happy is your wife is you? So we are happy that patients come in office and he's not complaining, so come on, okay, fine. If he's coming and saying, well, I have problems with my ED, my sex is working fine, okay, prescription for sildenafil, go on. So that's easily to manage the problem, but that's wrong, because he will not be treated by a PD-5 inhibitor. It significantly impairs not only the quality of life of the patient, but the sex health too for the couple. We have data that there is higher miscarriage, higher rate of divorce in the patient suffering from PE. The quality of the partners is going to have to be considered. And this leads to consequent embarrassment and dissatisfaction of the patient. PE patients are psychologically really this only group, not the ED patient, but the PE patient, which have a problem. They have a social disturbance, they're not feeling himself fit, they're neither good in their career, in their psychological career. So it's a little high impact for the man not to be fine. Mostly widely used is the so-called intravaginal ejaculation latency time. It seems if you are addressing the question, do you have a PE, it's not important for me to understand how long you need for your arousal, what is your foreplay. So I'm not interested to understand what is the relation between you and your wife, how long you kissed before. I'm asking, well, at the moment when you penetrate vaginally, how long needs that you can ejaculate? How can you control that? That's a key point. So if he's making 1 hour sex and spending 50 minutes, 55 minutes only with kissing her wife, and if he needs 5 minutes for his ejaculation, we have a problem. So here we have to understand where is really the problem. Not only ask the question, how is the sex, how long takes the sex. The sex time is irrelevant. So remember, the plateau first is the important issue. We have different definitions, and that's a simple question for the patient. You can address this in 2 seconds. Lifelong is acquired, and it's a natural barrier or premature light ejaculation. So that's all I need to understand, because it determines the treatment completely. So lifelong, it seems you have to ask it, is it happen every time? All your life, with every woman, everywhere, independently, in your hotel, in the house, in the neighbor house, in the holidays, seasonally, that's lifelong. So every woman, nearly all occasions, always did. You had it always. He's suffering from the whole life, from the first experience. Acquired is completely differently. He got it maybe after 40 cases, saying, hi doctor, now I have a problem. I ejaculated early with the same wife, I don't know why, everything's same, we had a good life, but now it's not working. Here I might have a prostatitis. You treat that, and he's happy, saying, doctor, you have to help me. So it's inconsistent during the life, and rapid ejaculation during that some time in his life. And then it's the mixed type is the natural variable type, so we can go. Most important, So we have, to understand, we have different types. The most prevalent subtypes is the nature variable, it happens sometimes, or the premature life dysfunction. This we have to distinct from the lifelong, and we have some cofactors, and that is a problem to understand, because the patients complain saying, I have a problem with my sex, I'm not working, my penis is not working, and there's an increase found that the concomitant erectile dysfunction diagnosed. The risk is 1.95, so really high, and it is affecting with depression. So he became depressed, not because he was depressed, but he became depressed because he has his ED. Sometimes he has an EP, he becomes depressed. And it's correlated with physical activity. So a man who is not physical activity has higher risk to get a premature ejaculation. So, problem is the exact etiology, we have no data. Marcel Waldinger have done a lot of good studies 20 years ago, 15 years ago, until he died. But he was really a clever guy, but we don't know exactly. But fact is, and that's important to understand, we have disrupted neurotransmitter supraspinal in the central nerve system for different molecules. And if something with the molecule in the brain are not working, we have a problem. Most important is the serotonin, 5-hydroxytryptamine, serotonin, the noradrenaline, oxytocin, noradrenaline, oxytocin, and GABA. But 5-HT, serotonin is the most important. Secondly, we know from genetic studies that there's a link by genes. So it seems we have a patient which by his own genes he cannot do else. He's a genetic link disease. So that was shown as a genetic predisposition, and there's an increased sensitivity of the glands to penis, apparently. He has an ED, he has a genital morpholism, and we have this hormone imbalance in some cases. So, I want to understand, do I have this excitement in the brain, and underline always, orgasm is a question of our brain. The orgasm is here and not in the penis in the man. So something here is not working, and the most important molecule hormone is the serotonin. This is neurotransmitter which is crucial for us. So from this neurotransmitter serotonin we know at least 14 different receptors. Not all one of these serotonins are important, but it was shown in the 60s that with this the animal studies, with these receptors, the serotonin, we can affect, we can change it, and the rabbits here have been highly active, make a lot of sex. From all these 14 different serotonin receptors in the brain, only a few ones are important, and I highlighted for you 5-HT1A, 1A and 2C. One is blocking and one is exciting. So the same molecule, dependency where it's going on with the target, is working differently. So they have to understand it. We have not only to see the concentration of a molecule, the functional aspect means the molecule has to find a receptor. And that more receptor from exciting phase, same amount of molecule will be a result in a physiological reaction of more excitement. So that here we have this imbalance, and that was shown in genetic studies. The other ones are not important. So to keep it simple, hypersensitive is here somehow a link to the serotonin receptor 1A is pro-ejaculatory, and the 2C is delayed. And if we have an imbalance, both receptors are present, but the imbalance is linking to disturbance in the serotonergic system, and we have higher risk of EP. So now you got the information. At first, it's a hormonal triggered neurotransmitter linked disease, and it's working on the brain and not on the penis. That's how you understand. That's important for the next step. So we have different pathways, and this serotonergic is completely different from the dopaminergic. We spoke until now already about these serotonergic pathways, different or involved, so to make everything more complicated. How we can diagnose it? Who has any idea? So that's difficult because you have different definitions for the diagnosis. But please take a mention that if you look to the patient before they come to your office, how many trials they got by their own, how many different treatments they got. That's incredible. Nearly 5 different treatments they got until they came to your office. So long story, and what they're doing. So they do not the right one, they get the right medication prescription. No, they're here. They're focusing on the sex, they're focusing on something, not pleasure. 60%. They interrupt the stimulation. So think about how pleasurable that may be for the couple, for the female to think, oh darling, you're so sweetie, but now I'm near to my orgasm. I know you like it, but we have to stop it, and maybe in a couple of minutes we are restarting. So surely that's not good. They're going to make a masturbation before, there's using a special position until it's worse. A lot of adolescents are using alcohols because that's delaying a factor that becomes a toxic situation. But you see, if you counted how many different attempts they had, nearly 5 different attempts they used before they came to your consultation. So I think it's a critical issue. And therefore we have to understand what is considered as premature ejaculation. And I will go on you on this slow, fast. You can read it everything in the paper, but you can, in this table I make for you, different definition. ICD definition, it's not same as the DSM-5, not the same as the SAI. You see in ICD-11, which we're using every day, that is not specified the intervaginal latency time. It's the difference. Here you have 3 minutes, here you have 1 minute or less. That's a crux in the definition. So we have a huge difference in different guidelines, and not each one is reported the same one. Each one, but on the other side, is stating that this has a huge distress factor for the partner and for the female in each of this category. And now I'm going to show you the European and American one. It's pretty much the same. AOA, American one, European one, you see, 1 minute for lifelong, 3 minutes for acquired. US, 2 minutes for lifelong, not specified for the acquired. ESSM, the Specific Society for Sexual Medicine, 1 minute for lifelong, 3 minutes for acquired. You see, that's not always the same. And the therapy again is not always the same. So that's the reason why I have no clear data. But at least, let's assume we are clever, we make the diagnosis the patient has a PE and not an ED. What you should do in this case? So he asking you a treatment, what are you offering this one? Well, I have to say there are different options according to guidelines. While there are on-demand local anesthesias, which I don't like it, they have a high rate of dissatisfaction, 75. They have a high dropout, about only 10% in 1 year. So to consult your patient while use your anesthetic cream will be not happy for him, and neither for his wife, because he has to wash it away if elsewhere his wife became a pain in her vagina. So importantly, behavior training, yeah, it's great, you're always good, send your patient to the psychiatry and say, make a good training, yeah, you can do that. And the goal is of course to have a highest confidence, to alleviate the anxiety, the depression scale, but in the short term, the success rate, 30 to 50%. So, modest. So he has to go every week to the psychologist to discuss my problems and the background, knowing that we have a problem brain. But he discusses a lot. Long term is not certain. So then we have in long time we use serotonin reuptake inhibitors. But the problem was that most of them are used off-label, not allowed. So you're taking the risk if you're prescribing that, even as they're working. SSRI, you have to decide it, are you using on daily dose or on demand? Only dapagliflozin is the only available in Europe, which has allowed, but has on the other side no FDA approval in US. I don't know in America if it's allowed, but you have to be careful. You have a problem if you're using medication which are not allowed. I don't know Russia what they're using, but dapagliflozin is well working. I will show you how the good data has. So you see, the treatment can be on demand of anesthesias. We can do, that's good, a physiotherapy with electrostimulation of the pelvis, this is good. We are using SSRIs or clomipramine. We use PD5 in combination with dapagliflozin, PD5 alone or in combination, or tramadol. These are all options, for example, which we have to discuss it to figure out where we stand, what we can offer to our patients. The most common drugs, as you can see, for the SRI group, have here a problem. And if you look at pharmacology before you prescribe something, look always in the prescription, what's the T half time. And you see, clomipramine, T half time, since after this time I have 50% of the dose in my body. That means T half time. 20 hours, 37 hours. Fluoxetine, 37 hours. If I take one tablet, I have for 36 hours, I have the half of the drug doses, and the next 36 hours, I have the next half. So you have a long delay of the medication. It seems if you're using twice every day one pill, you have an accumulation rate with a lot of side effects. So be careful. Paroxetine, serotonin, you see, they are all long. The only short one is dapaxetine. You see, half time, 1.5 hours. Dapaxetine is the only SRI with a short half-life time. Tramadol, 5 to 6 hours. So you see, that's differently from this one. So we have to think about which one we can use and which one is an option. Furthermore, we have data that this kind of drug, these SSRIs, have a negative impact for the sperms. So if you have a couple which is like to have sex, but they want to conceive a baby, and you give a medication what is killing the sperms, or is decreasing testosterone, surely you're doing not a good job. I think your job should be better. So think about only pharmacology. And therefore you should understand two issues. So what is doing dapaxetine, this medication? It's improving the release of the vesicle in the presynaptic nerves, releasing that on here and blocking at the same time the reabsorption rate. So that means at the end of the day, we have a higher concentration of 5-hydroxytryptamine for serotonin in this here. So reduce the cleavage in this area, in the neurons. Then you have more serotonin there. That's the mechanisms. And that's great. So it's work centrally, not on the penis. You gave a medication on the brain. You gave a medication on the brain, which is increasing the concentration. So therefore, it was really nice to see how the news or in the US are reporting this medication, how we can increase our sex life on this medication, and this was correct. See the green line, this is classical doses, 30 milligrams we're using. You're taking the patient, taking the medication before, and look how it is next day. And you can say, well, the next day you have nothing about it. No side effects would be expected if he's using it in the evening. If you're using the 60 milligram, the highest doses on the market, you see more or less the same curve. T half time is important to understand the mechanism of this medication. And that's completely different from medication what you use in the long term. You see, that's other SSRIs which are proved to be good for the premature ejaculation, but you have here a long time, long delay, and if the next day he wants again, then he will increase the next time. That's shown for different. Only dapaxetine is have a short time. So this is only medication which gives for me sense for the patient to use it. In fact, you can use it several times, and you can see you have an improvement measured by 1,000 men. Look into the intravaginal latency time compared to placebo. If you're using for a long time, you have a stable situation. After 5, 6 tablets, you're reaching a stable state. It can go on a long time. Whereas placebo is increasing a little bit. When you see the ERT in minutes, shortly increasing, but it's going down again. So placebo is not working, medication. So you should choose a correct one. I was the PI for this study published in the European Urology, when was it, 2011, the tramadol hydrochloride study. There was another option, instead to use the, this time it was not available tramadol, was available dapaxetine. We used tramadol hydrochloride as oral dispensable, and indeed we checked by the stopwatch technique the increase, and you can see we used tramadol oral dispensable form, a special one, not commercialized on the market, but from a 2.5, 2.75 ELT time in the placebo group, we could increase for double. You might say, oh, it's not so much, 2 minutes, 4 minutes, but for the patient, that's a new world. So if he ejaculates in 1 minute and then he had 3 minutes, he's a new world, he's a new man. So that you see, the dosage of tramadol, which I contributed to this study, was really good. This was hard cases because before they had always below than 2 minutes. What are the treatments according to the guidelines? Only make it clear for you. You see different guidelines, EAU, American ESM. Here is written on-demand dapagliflozin. Look on the American one. Dapagliflozin is not, it's an asterisk here, is not allowed by the FDA approval. You cannot prescribe it. You can use on-demand tramadol, even less as second-line therapy. In Europe, the EAU, Euroguided dapagliflozin, topical anesthesia alone or combined, topical anesthesia alternatively, pedifine alone or combination, tramadol alternatively, and psychological treatment and so on. But you see, we have no uniform picture according to guidelines, and you have already checked in which country you are and which are the options according to which guideline you have to see, and you can do a lot of this thing. I think this one are better medication, dapagliflozin, instead of daily SSRI, because daily SSRI has a withdrawal effect, have a long-term effect. So you know, if you're taking it always SSRI, you cannot drive the car. You have to tell the patients, okay, I'm not sure if I can gave it to my colleague in the hospital, if can you operate? I'm not sure if it's a legal issue, then he cannot drive the car. So we have to be careful with it. The same for the Asians. And the ECD, of course, is mentioned nothing on the treatment. DCMN, of course, gave no information for us. But here is more important to understand, and the newest, 1 month before it's released, that if there's same time and erectile dysfunction, treat the ED first, make the penis hard. If not, you cannot control the ejaculation. That's here new in this guideline recently for 1 month or so. This has been published, this one, the CMS guidelines. Okay. Having new technologies, is there something new in the market? Well, there's propagated a lot of neuromuscular electrostimulation therapy. I'm not sure if that's really working. Recently in Nature published this article, Nature Review article, published this article from this 2-in-2 patch compared to MyHixel and TPNS. If I'm looking to the data, honestly, I will show you yourself what the company are reporting, and I wanted to know if you would be satisfied with these comments. These are original. These were original sites from different companies, which are explaining. But honestly, we have no data about that. Neither for this virility patch from the Israelis group, if there's a good guy behind that, it's a commercial product. So I don't know what's working, if it's true or not. And you have to masturbate before with a strange mechanism. You have to use the patch, which is going with electric stimulation, but there's no data proving that one of these is working. So even less, I'm a guy who is believing technology for improving the muscle tension, and the concept might be right, but still now, virility or Mayora has no proven data. So I have more or less to conclude, we have no clear data about the definite cure, and for P still missing, is elusive, we don't have nothing there. It's a question of the brain, supraspinal. And I think it's your job as urologist to do your best, because only then, Joe, on the beginning, the Joe will be happy, your patient will be happy, and John Doe. So you have to all do what you can. That's my conclusion in a short time. Thanks a lot.
Yeah, but really, I must give my compliments to you, because you performed a really beautiful and comprehensive lecture on all the root problem of the premature ejaculation. Yes, I must say that I was involved in premature ejaculation since the beginning of my activity, so 50 years ago. And I suppose that the first paper published on the physical aspect, not psychological, as all the psychologists at that time used to say of premature ejaculation. On premature was a neurological paper I published 40 years ago. Okay, and in these years, the same years, 1 year later, I published a paper on the use of clomipramine.
Yeah. Okay.
Clomipramine for as a treatment, possible treatment of premature ejaculation, showing that apparently the drug was able to modify the sacral vocal potentials, okay, in this kind of patients. Well, I must say that you presented everything in a very comprehensive way, but at the end, when you know that as andrologists, when we face a patient suffering from premature ejaculation, we have a lot of doubts because okay, all the normal treatments, the most used treatment, the dapoxetine, okay, but I don't know what is your experience, but in my own experience, the dropout percentage of patients is extremely high because dapoxetine, yes, it works, but has also heavy side effects. You must inform the patient. If you want to obtain a better result, you must increase the dose, and the side effects increases, and so this may be a problem for the dropout. About the SSRI, I must say that in my experience, many of them, the paroxetine, etc., are at the end. Yes, they can delay the premature ejaculation, but the ejaculation process, but also the sexual interest goes down.
Yeah.
Okay.
Low testosterone.
Yes, in fact, and in many cases also, you are you oblige the patient to be dependent on this drug because you cannot stop suddenly the therapy because there are so huge side effects.
You will be this
yes,
way maybe.
Yes,
high risk of the
yes, and some patients can have suicide ideas. Okay.
Correct.
So, well, and if I the topic, 50 years ago, a company presented me a topical agent with an anti-anesthetic cream. So 50 years later, the situation is more or less the same.
Yeah.
And if I must, to conclude, if I must be sincere, now when I see a young patient, this is my personal experience, a young patient suffering from premature ejaculation, I go on using as a first option clomipramine, and I identified a personal therapy, if someone of you is interested in it, because I have been using it for decades. Okay, that is, I prescribe the first pill 10 milligrams about 2 hours before possible sexual experience. Okay, to go on with this prescription for 10 days, and after 3-4 days you can evaluate your situation, and if you are okay, you go on taking the drug at the same dose. Otherwise, you can increase the dosage. Yeah. So 10 milligrams in the early afternoon and 10 milligrams before dinner. Yes, and for other 10 days. And in order to avoid that the patient loses the effect of I suggest to stop every month during the menstrual cycle, okay, and to begin again. And really, this is incredible, but after 40 years, I find that this drug, this therapy is already better, at least in my experience, than all the other much newer that you presented. Okay, it is not a criticism to your presentation, absolutely, clearly. But I want to share my personal experience.
I think that's very important because I didn't cover everything, so I didn't go in detail about the possibility for the psychotherapy, which I'm still using. That's correct. And the benefits in selective cases, you have very clear markers, different diagnostic criteria, and neither I expressed all the agents, but I want to see what is here on the guidelines.
Yes, no.
The problem, what I'm saying, is that we must be clear, all that what you're using outside any guideline, or outside any approval, FDA approval, LMA approval, it's in your own risk, including inhibitory. What you're using is again one of these substances which are good but are off level. So we have a problem. We used for many years the SSRIs on the off-level basis or on the daily dose, on demand means that. And for Clomid, he has to use it 2 hours before, which is long for the couple. It's not a pleasure factor. And the SRI for daily dose has a wide trouble effect. You have to be careful because if not, he will wake up and makes it for 2 weeks or it's a tick like this. I think we are not happy if you like living this way. So you see, you have a lot of problems. And concerning the acceptance rate for duloxetine, now Prigi is well accepted. The promises to prices to high. Even less meanwhile, Italian company, the company Menarini Pharma is bought this license, has too high the prices. So the acceptance rate and side effects are low. You should only not drink more than 1 or 2 glasses of wine, because then you had in the license study a high risk of orthostatic hypotension, which in real world data didn't show neither. So it was really similar, but it was the first warning it was written. So as long as the one is not drinking too much alcohol, and he will use it 1 hour before, as like Viagra, he is doing fine with that. So he makes a long loving kissing face, and he will be fine. Side effect, basically, it's not my concern for the BD5. So at least I mentioned this way that I'm prescribing Privilegy, the prescription for 60 milligram, and he has to buy it with 30 milligrams because it's the same price. You can you can divide it, or in pharmacology it's the same, and the price is high, so he has to pay around €3 per 1 tablet, which is enough. But if you're using 1 time per week a Sax, then I think 3 hours is like a glass of beer. I think then, or wine, we're not happy. So the acceptance rate wasn't so bad. And if it's not working, at least I could prove that I used the legal approval medication and switched them to tramadol, which is really fine and it's not expensive, the best on the market also for the pharmacology. But Clomid is a good idea. Clomid is good. Other questions? Yes, sir. Sergey.
What do you think about hyaluronic acid injection implants of the skin?
Okay, if you followed my instructions or my lessons, I stated clearly that premature ejaculation is linked to higher sensitivity on the penis, but it's a supraspinal cerebral issue. So why should I intervene with a strange, not allowed technique which is destroying the penis in the long term and makes a lot of problem when the problem is there? So honestly, no way for me. I'm not using it. I saw a lot of complication with this injection therapy. I see there have been a lot of surgery done even in Milano. I saw many patients who then they're using laser therapy to destroy the nerves. A catastrophic situation because they have no sensibility, and then you have a penis with no sensibility on permanent. So forget it. I think that's not a good idea. Okay, just enough to use local anesthesia to reduce the sensitivity and have not a good feeling for the sex. Sorry, I just have a problem there, but at least that is not permanent. It's shortly, at least, when the man is washing his penis after the application for 10 minutes, because elsewhere, if he's not using condom, he's bringing this lipophilic substance to the vagina, and so the female feels nothing, and he has dyspareunia, more pain. So we have to instruct the patient to wash it. Okay?
Okay,
Someone else?
okay. With the questions?
This was for the ED talk.
Yeah, so we can go to the ED talk, so before we make the conclusions.
Well, I want to inform all the audience that
There is some.
We have one more question. So, if I understood it right, we have the panel, I think we can shorten.
It's already
Yeah,
6 p.m.
they come, yeah, they come.
It's
So we have the last question now,
Late.
for the time. The last question, what we have on you, please go address the question.
Just a comment about this new topical gel that they're selling over the counter that is now FDA approved. There's this topical gel that was recently approved, I think it's called...
Vitaros is approved in Europe.
Not Vitaros,
The
it's a topical that you put on the glands that you can
Yes.
buy over the counter. It's called steam gel or something like that you don't need a prescription for. Just release
Talking
like
about ultra study or any?
No, it's
For
called
erection.
steam gel or something like that.
yes, it was spray.
You can just buy it over the counter, you don't need a prescription. It was just
For
recently-
erection or-
Yeah,
For
ED.
erection and for the delay of ejaculation.
ED, erection.
For erection.
Yeah, not heard about it, no?
I don't know what it is.
Okay.
But regarding medication is Vitaros that it is cream and prostate.
Ginseng, also local ginseng, oral and local.
No, this is just recently, like literally 2 or 3 months ago. It was all over the news. Men can go to the over the counter, they can buy from